Crazy training. That's on every sport walk-up song. But when I was in high school, people, would write Ozzy across the fingers like him. But I saw it on that line. I saw his Instagram yesterday. I probably should. I know y'all are like, why do you say you shouldn't say that? Because everybody thinks you should cuss all the time. But I don't. Doesn't make it sound smart. Anyway, the Instagram had this guy, a bunch of people sitting down, and this guy like flexing or something, and it said Ozzy Osbourne up there with all the other past rock and roll people who OD'd, going, I smell bitch in here. Sorry. Could be true. There's another one out there that says that they're naming all these rockers and things that outlived Richard Simmons. And if you don't know Richard Simmons, he's a fitness health nut guy. Anyway, I don't know. I know you have today. We get to do anatomy. We're here. We woke up. Yesterday's gone, so it doesn't really matter. Tomorrow may not come, so it really doesn't matter either. But you got today. You need to still say it because you may live as long as I do. All right. That was a good opener. I didn't have one. I'm running a little tired again today. I realized one thing that I didn't think of. Because I haven't ran for so many years. I was feeling great. I realized that I still love running. I just don't do it anymore. But now that I started again. But I woke up this morning and I went, I don't remember my upper body ever hurting from running. Anybody know what I mean? I'm like, my upper body is more sore than my legs today. I'm like, was I struggling or something? I feel like I was struggling. I was running like turtle pace. I'll get there. In about, I told you, about 5 years, maybe sooner, I'm going to start, y'all need to befriend me, to hold me to it, right? Y'all are my accountability that I keep doing. I'm posting first, second 5Ks I run. We'll see how I do. Who knows? I'm only telling y'all that to make myself accountable, like somebody said. Because now you're going to come back and think, you wussy, you didn't do it. Okay, scapulohumeral muscles, kind of where we left off yesterday. We're going to look at muscles of the shoulder. Now you get these names that are different. It sounds like there's so many different groups. But when they look at muscles, they'll name, like, they want to talk about a group. Like, people will go, oh yeah, the rotator cuff muscles. That's a group. Well, the rotator cuff muscles are part of the scapulohumeral muscles. So when you start getting tripped up by all these different ways of naming them in their little groups, just think about what it says, scapulohumeral muscles. So muscles that go from the scapula to the humerus. And then some of those compose the rotator cuff. Not all of it, but they're named for kind of what kind of group they are. So in this group, we include the deltoid, then we have supraspinatus, infraspinatus, teres minor, teres major, and subscapularis. So out of those, 4 of those are going to be our rotator cuff muscles, and we'll discuss that here in a second. The first one we're going to look at here is the deltoid. If you look back to your trapezius, it had its insertion at the same point I said as the deltoid. So the deltoid origin is the clavicle, the acromion, and you can't see it here, but the scapular spine in the back. Maybe it's better to look at this picture where you can kind of see. This is posterior over here, so this is the scapular spine, the acromion, and then part of your clavicle. So that's how the deltoid's set up, and it's actually, you could further divide it, it's muscle fibers. It's going to insert at the deltoid tuberosity, but picture it in 3 separate pieces because it's a multi-pennant muscle. It has multiple actions. So when you look at the deltoid, the entire muscle, its job is to do abduction. Specifically, once you get a little bit ways up, your deltoid kicks in. The supraspinatus does the initial, but then your deltoids help you bring you up into abduction. But the anterior fibers can actually flex the shoulder. So you're going to flex the shoulder, or the posterior fibers are going to extend the shoulder. as we look at that, you still have to think of it has other actions, because if you look at the anterior fibers, remember they're pulling this way, that means that they're going to help medially rotate the humerus. And the posterior fibers on the back are going to help to laterally rotate it. We have a lot of different muscles associated with scapulohumeral muscles that have action on rotating the humerus. Deltoid does kind of both, medial and lateral rotation. And its innervation is going to be the axillary. The only way I can think of, remember that, is it's overlying the axilla. It doesn't help a whole lot. So like I said, there's your deltoid. Supraspinatus, when we looked at the scapula, we had the scapular spine, and then we have the supraspinous fossa. And that fossa, all of that is really the origin for supraspinatus, and it's going to insert at the greater tubercle. Actually, a lot of these are going to insert at the greater tubercle, 3 of them at least. So the supraspinatus goes out there. Its whole job is it assists the deltoid, but specifically, supraspinatus is really responsible for the initial 10 degrees. So as you go and you say, well, I'm going to abduct my arms, that initial starting that happens with your supraspinatus, and it continues to help along with the deltoid as you go overhead. So if anybody ever asks, what muscle initiates abduction of the shoulder, we think of that large deltoid, but supraspinatus, they say, if you were to actually truly look at the way these muscles work, it initiates abduction. And it is suprascapular nerve. We heard that nerve before because when we have the suprascapular notch, we have a nerve that comes up anteriorly, goes through, right? Army goes over, Navy goes under. It's that same nerve. And so the suprascapular nerve goes through that notch, innervates supraspinatus, and the next one we're going to talk about, infraspinatus. So that's how they get their innervation. All right, so here's infraspinatus. If you haven't linked this in your mind, I know this sounds like Barney, like low level thought. One's above the scapular spine, one's below the scapular spine. Just another way to think of it, to remember them if you've never seen them. So supraspinatus, infraspinous, below the spine. Its job, or sorry, I didn't say its origin is the infraspinous fossa, and then you have an insertion at the greater tubercle. So if we look at how it's going to pull and act on that humerus, that means it's going to laterally rotate. It's going to laterally rotate the humerus. And it is also suprascapular nerve. And then teres minor also, all of these are originating off the scapula. It's going to originate off of the middle of the lateral border of the scapula, and it's also going to insert into the greater tubercle. And its job is also to laterally rotate the humerus, but because of the way it's angled, it can also help to adduct or bring it back towards midline. So it can laterally rotate and it can adduct. And along with deltoid, this one is also axillary nerve, which it runs pretty close to the axilla. Remember, I told you the shoulder muscles aren't as easy on the nerves. You'll see what I mean on the nerves today with the compartments. It makes them easier than these. Teres major. Remember, we have a teres major and a teres minor. Teres major is definitely part of the rotator cuff, or it's definitely not part of the rotator cuff. Teres minor is. I'll show you that under the rotator cuff section. But teres major originates off of the inferior lateral border of the scapula, kind of down by the inferior angle, and it inserts in the intertubercular sulcus. So in this picture, they don't, well, the bottom one does, that's why I put that in there. It's going from the posterior side of the scapula here to the anterior side of the humerus. And so now, the question that I would have asked you several classes ago, I don't ask, but I told you I wouldn't do insertions, can come back and say, can you name 3 muscles now we've talked about that insert at the intertubercular sulcus? That would be major, latissimus dorsi, and then teres major. So all of these. So if this one's going to contract, it's going to help to adduct the arm, and then it's going to immediately rotate, right? Because it's coming once again. It's like it's acting just like latissimus dorsi in its rotation, because it's coming here and attaching anteriorly. So when it contracts, it's going to immediately rotate it. And it is lower subscapular nerve. It is lower on the scapula. And the last one here that we've discussed, subscapularis. Subscapularis is on the anterior side of the scapula, and it encompasses a very large origin, the whole subscapular fossa, all of that. And then it's going to insert differently than the others. It's going to insert on the lesser tubercle. And it has one job, and that's to help immediately rotate the humerus. It's very large, and that's why I said it encompasses that whole area, so it gets upper and lower subscapular nerves for its innervation. I was having a thought, sorry, in my mind of making sure people understand. Like if you say, this muscle gets its nerve supply from this nerve, or this muscle's innervated by, and these are all, I had somebody on a few tests ago that didn't, somehow we made it through the lecture, and at the test they were like, well, I don't know what innervated, what does that mean? I'm like, well, what nerve supplies? And they're like, oh, I never linked that. It's another instructor type bias, right? So I'm saying it so nobody does that in here. I'm like, it's the same thing. Innervates it. The other thing is always looking at nerves directly makes a big difference. You know, that kind of stuff. Alright, then the all-important rotator cuff. There are four muscles that their tendons come together and form a common kind of like cuff, they call it, or sheath, where the tendons are combined and they go over the capsule of the shoulder. And they're very important to help hold the humeral head in there. Right? We hear a lot of people having problems with their rotator cuff. When you look at the muscles that are in it, it is supraspinatus, infraspinatus, teres minor, and then subscapularis. And if you've heard that, anybody ever heard of SITS, that's how you remember them. I write it a little differently because for people who've never learned the rotator cuff muscles, the first thing they're going to do is somebody's going to ask them what are the rotator cuff muscles, and they'll throw in teres major. Or they confuse major and minor. So I write it like this in my mind, and I do it for y'all. So when you write SITS, we have supraspinatus. I write a lowercase I because that's infraspinatus, and then I write a lowercase t to remind me that that's teres minor. And then of course we have subscapularis. That's how I write SITS, so I don't forget, because you'll forget. If I'm not in here, I'm out in clinic, I'll forget that it's major versus minor, even myself. But having taught this for a long time now, when you get into the lab and we look at it, I'll show you on pictures, but really when we get into the lab and we see teres major, it drives the point home, is minors, like going up here. Major actually inserts a lot further down. Right, because remember, we looked at teres major and it went out to the intertubercular sulcus, which is much lower than the tubercles. That's the bicipital groove is here, and so it's inserting much lower than where the rotator cuff muscles are. And there's a big gap. If you look at a specimen, you can actually see there's a gap to remind you that major can't act on that area. Right. So in general, if you talk about the muscles of the rotator cuff, you would say most of them, 3 out of the 4, insert on the greater tubercle, and then subscapularis, the outlier, inserts on the lesser tubercle. So their whole job is to lift, stabilize, and rotate the glenohumeral joint. We're talking about muscle specifically. We call it shoulder within the joint. That glenohumeral joint where it connects, all of them except supraspinatus will do some type of rotation. Supraspinatus only does initiation and continuing abduction. here's the muscles again, all together, that make up our sits group, or our rotator cuff muscles. I gave you another view here, kind of like this, just because of the way you can see how, like, supraspinatus, subscapularis here. You have infraspinatus down here below the spine. You can't see it back, this portion back there where I wrote that I, but then teres minor is here. So all of them make this nice cuff to help hold that shoulder joint in. I like that picture because it's a good one to show, like, if all those muscles are kind of tight, like they should be, have that tone, it's going to help to hold that humeral head very well as it can into that joint. I put lots of pictures in here because I like, rotator cuff is one of the things that we kind of got to understand. You're going to learn to do a lot of testing on it. So it comes back to somebody's question yesterday about the bursa that are under there. I'll get to that in a second. But real quickly, we're just going to flip through these. But this is another view, anterior view, where we can see subscapularis. I left these in here just for y'all's orientation. Subscapularis again. Remember, I told you, if you want to look for orientating a picture of the shoulder, whether you're anterior or posterior, first thing you should look for is there a biceps tendon going into the capsule, or out of the capsule actually, because it originates higher. And of course you have your acromion here, coracoid. And supraspinatus coming down through that area. Here's another view of supraspinatus. It goes down to greater cervical and then infraspinatus down below. If you cut away part of supraspinatus, infraspinatus, you can see a few things, such as that artery and nerve, right? The artery going over that, and then the nerve going under, suprascapular. And it shows how it comes down here and innervates supraspinatus and infraspinatus. But then you can find teres minor a lot easier also. Major would be down here. Doesn't look like it in the picture, but it's further down than you think. Okay, so I wanted to talk, because you see a lot of these, I said yesterday, on like deployments and things, just in general in the military, shoulder, inflammations, problems. So you have the acromion and the coracoid, and there's a ligament that goes between them called the coracoacromial ligament that we find right here. And what it's going to do is help prevent displacing your humerus superiorly. Right? So we look at all the ways that we can stabilize the shoulder, and there's a ligament that crosses here. It's straight across from the acromion to the coracoid. And it helps to keep your shoulder, you've been driving that up. It's not like a bony area. The posterior side of the glenoid is a bony kind of area because you can't really take the shoulder. If you take your shoulder out posteriorly, you're probably going to tear the labrum that's there or fracture off part of that glenoid, depending on how severe it was. But I'm mentioning this ligament because it's preventing the head of the humerus from going superiorly. Well, in between the acromion and that ligament that goes over the coracoid, there is the subacromial bursa. A lot of times there's also a deltoid bursa, and a lot of times the subacromial deltoid are kind of connected. The most prevalent one we talk about is the subacromial bursa. And so if you've ever heard of painful arch syndrome, that's where somebody goes to take their arms, and we were talking about with side straddle hops, you want to turn. Remember I said that what you're going to do if you don't turn your hands over is you're going to drive. You have that ligament, bony block, you have the humeral head, and between them you have a bursa. And so if you've inflamed that, and you get up to over 90 and you ask them to take their arms overhead, they're going to be kind of impinging on that bursa. They're going to put pressure on it. And if you were to do a bunch of side straddle hops that are just not turning your hands, you would certainly, you're going to be driving the head of that humerus into that bursa the whole time. That's why we turn it so you can clear. But you'll see people come in with subacromial bursitis in it, And that's what I said, one of the easiest like injections there is to do if you know what you're doing. And there's different methods, but I was taught to just come back and you get your 1.5 inch needle there. We don't need to get into specifics, but you find the spine of the acromion. I'm not here to teach you injections. You do not know how to do it after this. You get your steroid and probably some lidocaine in there, and you got your needle, and you can find the scapular spine, and then just below that, it's kind of notched. And you want to go right inside of there. And what I do, and was taught to do, is take the cap of the needle before you clean it, right, and put a little pushing, leave a little indentation there, then clean it off, and that indentation will still be there with a bit of red at least. Then you can take your needle and just go straight in. I'm aiming for just below the scapular spine. A lot of times you'll bump into that. You just kind of act up a little bit and go under. It's a good landmark to find. Oh yeah, I'm right there. It's just under there. When you go into that bursa and you put that needle in there, anytime you do a steroid injection, if you're having trouble at all pushing the plunger on that syringe, you are not in a bursa. You may be in a tendon. If you inject steroid in a tendon, that's not going to be good. It probably can cause it to rupture. Doesn't mean it will, but you know when you're in the bursa because it's almost like the plunger falls. You know what I mean by falls? There's no resistance. Just gone. It's like giving a flu shot. You know? Right in there. If you have to push that thing at all, you're not in the bursa.
Can you aspirate anything whatever you're in the bursa?
I mean, you could. I mean, in that case, you wouldn't want to unless. If you were looking for an infection, like bursitis due to an infection or something, you could. But I've never done it there. In the knee lead, yeah. That's typically from the inside of the synovial capsule. But I'm getting a little bit ahead. In the knee, we have a lot of bursa. And then we have a synovial capsule. But those bursa, a lot of times, are continuous because it's the same type of fluid. But we're not going to get into that deep of a discussion of the knee. But yeah, you could. I always ask you, why would you want to draw out a bursa? Just thinking in general?
Just like confirming you're in there.
Oh, yeah. But you really don't need to. You can tell. But some people do. Sure. I was thinking of infection, like you wanted a sample of that.
Oh.
I would do a few injections. There's things that I will not do as a PA, especially on the civilian side, because if you mess it up, you get sued. Of course, I work for the VA and the government. I mean, what am I worried about? Hold on, just a second. I gotta finish my thought. Minor fasciitis, I used to do those until I went to phase 2. I did them as medic, I was taught. And if you miss, I'll tell you this again during long extremity, I know. If you miss and put that steroid in the fat pad under their foot, it will disintegrate. Okay, and that's not going to be a good thing. We're walking on bone. The other one is anything close to the tendons of the wrist, like your aspirating cyst and stuff. I don't care to deal with that. There's too much going on in that area. But yeah.
I was wondering in cases of rotator cuff arthropathy, with that coracoacromial ligament, is it possible to see the head of the humerus start fraying that ligament because it's starting to go up so much?
Yeah. That's part, and it's going to cause bony degenerative changes of the acromion too. A lot of that is like feeding on each other. Because the more older you get, the more arterioactive, the more arthritic it gets up in there. It doesn't just affect the glenoid, it affects that acromion being inflamed. We'll get arthritic changes. And you can start to get spurs at the top of your acromion, which is definitely going to inflame the bursa. What do they call that around here? The circle of the, what's the word for it? There's a famous, I'll think of it in a second. It's not the unhappy triad. Vicious cycle. I heard that a lot when I was in PA school. I don't use it so much. It's a vicious cycle. One's going to help lead to the other. All right. Axillary artery. We're going to divide the axillary artery, and it's going to seem, like I like to say, a little bit confusing at first, but I'm going to show you how to break it down into what its parts are and color code it up, and then reason through where it would be providing blood supply to. So the area that includes the axillary artery is kind of at the border of the first rib over here. And then, remember it came off of the subclavian, now it's axillary, and then it's going to go over here to the inferior border of teres major. Now this picture has the arm extended, abducted. Right? And in that case, it doesn't look like it, but if the arm's lowered, we'll see in the specimens, you'll be able to see that's actually, this is the inferior border of teres major. Once it reaches there, it becomes the brachial artery. So subclavian, axillary, brachial artery. Well, brachial artery is part of the arm. We're talking about up in the shoulder. So we need to kind of look at, and yes, it does become important in some areas if you go into it. So we're going to look at, well, what are the main arterial branches that come off of the axillary artery? And so it's actually kind of divided by pictures into three parts. And it works out to where the three different parts is, the first part has one branch, the second part has two branches, third part has three branches. Somebody, like OCD, right, came up and said, hey, let's organize this where it works better. So it's confusing as you look at this Netter's picture here, with all these blocks. I should go and clean the rest off, I know. Okay, some things just don't get done. No. A box stop and color code is what we need to know here. Okay, so look up here, this is the axillary artery. That's the first part. There is only one arterial branch that comes off of that, and that is in, I guess, purple there, superior thoracic artery. Right? Where does it look like it's providing blood to? Is that the superior thoracic area? Yeah, they're all kind of like that, to where they're going. So if you're trying to label this type of picture, look at where they're going. Same thing when you do nerves, right? The second part, second part is between those two lines, and it has two branches off of it. Right? My own colored lines kind of confuse it up a bit, but when you look at the first one, it's coming off of here. That is called the thoracoacromial artery. So, thorax and acromion. If you were to follow the branches, stare at it hard, you will see that this branch comes off of here, but then it kind of goes back. This is still that branch going back towards these areas. You kind of see that, I know I just drew all over it. So that's the first branch, thoracoacromial. Part of the thorax, part of the acromion. The second branch is the lateral thoracic artery. And guess where it's going? Yeah, I know. Gets old after a while, right? When I keep doing that. Going down the lateral side of the thorax. It's not old when you hear that in your head, and now you hear it on a 10. I just say lateral. Third branch. And we can simplify this one a little bit by saying, okay, there's a third portion of the axillary artery before it becomes the brachial artery. Two of the branches that come off of there are called circumflex branches. They just go around the head of the humerus, so like around where the surgical neck is. And so you have the anterior circumflex branch, and then you have a posterior branch, and they just make a circle around below the head of the humerus. So then we really only got to think about one. And now, if you really look at this picture, I'm going to draw another line here. This is the lateral part of the thorax, the ribs. But this is the lateral border of the scapula. So this area, I'm going to really make it jumbled up. This area in here is the subscapularis, where the subscapularis muscle is. Subscapular region of the scapula. So it's it's actually going down that subscapular area, and that's called the subscapular artery. That's the way you divide them up. Should have left my markings off, but I like to draw while I'm talking about it. If you have an artery, you have a vein. So we have our axillary vein in this same region. we would say that the brachial vein becomes the axial vein at the inferior border of teres major because we're going back to the heart. And then it goes all the way to the first rib. So it's been dissected away here. We'll get back to how they join up when we get into the arm. Alright, so we get out of the shoulder and we get into the arm. I took out the title slide just to simplify the slide. This is a definite changing point where we're going to go, okay, well, let's really start learning these compartments. And I'll slow down a little bit so that sorry, I keep clearing my throat. It's like itchy today. If it bothers you, let me know. I mean, it probably won't stop because it's not my fault. Just trying to get y'all back away. Before we drone on. But I want you to listen to this part. For sure. The upper extremity, if you look at muscle origin and insertions, the biggest area for me and everybody else, I think, when you learn origin and insertions, especially if you're going to do pen testing, like in the lab, you don't know what that is, it's like going to gross anatomy, you have a cadaver, you walk up and they have sheets, I had one where they had like a drape here and a drape here. All I could see is this part of the forearm, and they just put a pin in one thing and say, you can't touch it. What is it? Like, holy crap. What I'm implying is the forearm has so many different muscles there, and they all kind of look the same. And so fortunate for us, we don't do pen testing here, and we're just going to learn what muscles are in each compartment. But I thought that was so unfair at the time because the muscles that are in your forearm go into your hand. And if I can visually see a tendon, I might see that it's going like spreading out to all four fingers, and I know that's flexor digitorum. But they had cut that part off. I didn't get that question right that day. And a lot of people would. It's a hard area. The forearm is the beast of muscle groups. You're going to see that, especially with the names. But I promise you this, whether it's true or not, I'll promise it to you. If you listen to me as we go through these arm and forearm muscles, I will make some sense into helping you categorize them, show you how to learn them, or you could say how to memorize them. However, you call it learning, memorizing, I'm not worried about it. My job here is to try and make it easier for you to remember them. And I'll break down the names. Because when we look at arm and forearm muscles, we're going to specifically look at compartments. These are muscles that are fully in the actual upper extremity. And we're going to see we have different groups, anterior, posterior, medial, superficial or deep groups. We have flexor or extensor groups. And then we have generalities, like most of the time, if you look at all the forearm muscles in the anterior compartment are generally flexors of the wrist, so they'll call it a flexor compartment also. So if we just focus in on the arm, and we have an anterior and a posterior compartment. There's only two compartments in the arm itself. The anterior compartment, the three muscles that are in it are biceps brachii, you have brachialis, and then a very small muscle called coracobrachialis. This is where I'm going to start driving home these. Use the name of the muscle. Remember back to muscle naming in that section I told you that you got to review again before the next test, those first 39 slides intro. I'll remind you again. When you look at coracobrachialis, that's telling you where it's originating from and where it's inserting to. The coracoid to the brachial region. So it's going from the coracoid to the humerus, coracobrachialis. Posteriorly, there's only two muscles. Triceps brachii, we've all heard of triceps. Probably never heard of anaconus. Small muscle, but it is back there. All the muscles of the arm are supplied by the brachial artery. So there's only two blood vessels that we're going to look at in the arm. One is the brachial artery, and one is called, it's really the deep brachial artery, but it's undie. I'll show you when we get to arterial supplies. I only mentioned it here because if you didn't know this, when you put on a DP cuff, the artery that you're compressing to take that blood pressure generally is the brachial artery. So our first true compartment that we're going to look at, this is your first generality. If you look at the anterior compartment of the arm, not the forearm, the arm, there are 3 muscles in it, and all 3 muscles are innervated by the same nerve. And that's going to be the musculocutaneous nerve. So if anybody has the chart up, take a glance at it, because I think glancing at that chart makes you realize, oh wow, that makes it easier. I can see that all of them are innervated by the same thing. They do similar actions, rather than viewing them as just one muscle all the time. Look for commonalities. So all anterior compartment muscles are innervated by musculocutaneous. First one here is biceps brachii, meaning biceps having 2 origins. So the long head of the biceps originates, remember it goes through the capsule of the shoulder, and it originates just above the glenoid on what's called the supraglenoid tubercle. And then it's going to travel down through the intertubercular sulcus. But you also have a short head that originates off of the coracoid process. For $100, can anybody tell me what muscle that we talked about already inserts on the coracoid process? Pectoralis minor. Throw that out. I wasn't going to give you $100 anyway. I mean, I'll give you a coin. I'll give you an A&P coin. You need one. Alright. So where's the insertion? If we go back to this makes it a key thought here. If we go back to look at its insertion, it inserts at the tuberosity of the radius, or what's radial tuberosity. And if you remember back to discussion on the radius, just below the radial head, we had a tuberosity. And so it's going to insert there, and often it kind of ties also into what's called the bicipital aponeurosis, which is the part of a tendon, the larger part of a tendon, sometimes called an aponeurosis, like the top of the head, and it'll kind of go over the cubital fossa area. But it's inserting at the radial tuberosity. So let's think about this when we look at these muscles. I need to get them to buy an upper extremity that you can hold up the way it's supposed to be. I don't like that one's always upside down. That's good for going through these muscles. The point I'm going to make is when you look at the biceps that's out here, it originates up here. The long head goes off the glenoid. Does it cross the shoulder joint? Yeah. It goes to the radial tuberosity. Does it cross the elbow joint? Yes. Remember what I said? You must pay attention to muscles and know kind of what joints do they cross, because that means when you're looking for its actions, you know it probably has an action associated now with the shoulder and the elbow. And that would be true, because the biceps brachii flexes the forearm at the elbow, and then it's going to additionally flex the arm at the shoulder joint. Alright, so it's doing both these actions. It can flex the forearm at the elbow, or it can flex the shoulder. Right? So it's crossing both those joints. It helps with supination. It's a very powerful supinator. We're not going to talk about that here because I like to talk about supination and pronation muscles all in I have a separate section for supinators and pronators. But as we go through the muscle compartments, I'm going to list like, okay, this is pronator quadratus. It belongs in this compartment. But we're going to talk about it under supinators and pronators. It works better as a group that way. Alright, and the innervation, because it's in the anterior compartment of the arm, is musculocutaneous. All 3 of these are. Then you have brachialis. Brachialis people don't talk about enough. Brachialis is actually the major flexor of your forearm. Okay, so that it originates lower down off the humerus. So see if you're tracking my thought process and I'm trying to show you things. If this originates down close to where you might say the deltoid tubercle is, right? It's down lower on the shaft of the humerus. That means it's in the anterior compartment, but it doesn't cross the shoulder. It does cross the elbow. That's the kind of points I'm trying to make, is so it has no action on the shoulder then. So it's going to cross the elbow. And I just told you, it's a major flexor of the elbow. It's also innervated by musculocutaneous nerve. And people who work out realize it's people who weightlift and things, because they're often doing these bicep curls, right? The bicep's most efficient when the elbow is flexed and the forearm is supinated, right? So if you want to work biceps, you're going to do them like this, right? But if you want to take that biceps kind of out of the equation, you can supinate your hands and do them like this, and that's going to work brachialis. So, like I said, very obvious to people who like to work out and stuff, lift weights, but that's why you're doing that both ways. I think I have another picture of this gentleman doing that. So now he's pronated his hands, and in pronation, when you're talking about flexion of the forearm, brachialis does most of the work. But they're both working all the time. Right? You're not taking them out, truly. Just if you'd like to work brachialis more than biceps, but both. Does it matter that you understand that as a weightlifter? No. You just know to do the exercises, right? You do them both ways. You know, just don't forget the legs. How about those guys? Sometimes things get weird with classes, and somebody came to me and said that the class leader had really done something to them to embarrass them. And so one of my slides in the lower extremity got changed to make sure you don't skip leg day. It was this big, the class leader was a big guy, he was like 6 something, I don't know. He was a big guy, worked out all the time. But they had taken the picture and made his legs like bird legs. And it was just a slide that was mixed in. It just came above the screen and said, something about, I forget the whole scenario. Make sure you don't skip leg day, and he says picture. I forgot to take that out of there for like 4 or 5 classes. That would come up in other classes, and I have to explain it. Y'all don't make fun of your class, do you? Every class is different. Last one here in this compartment is coracobrachialis, going from the coracoid process there, origin, and inserting on the humerus. So it does not go below and cross the elbow, but it does cross the shoulder, right? So this muscle is going to help flex and adduct, alpha delta, adduct the shoulder joint, and it's also going to be musculocutaneous nerve. So let's do our recap. If you look at the anterior compartment of the arm, it includes biceps brachii, brachialis, and then coracobrachialis. All 3 of those muscles are innervated by the same nerve, musculocutaneous nerve. And when you look at the differences, biceps brachii is the longer muscle, and it flexes the shoulder and the elbow. Brachialis is lower, it only flexes the elbow. Coracobrachialis is higher, and it only flexes the shoulder and adducts. Yeah, I mean, do y'all see how I'm breaking that down to kind of make it? The first step in this process, though, is, and I want you to think this way, if you don't do anything else before, like if you're going to study anything about upper extremity before unimportant, one of the things, first thing you need to do is memorize what muscles are in what compartment. Because that's the biggest thing that'll throw you off. And then we'll worry about what they mean. When we start saying, what do you mean flexor, digiti, minimi? We're going to have all these funny words. I need you to know what compartment they're in. Why? Because once you know what compartment muscles are in the upper extremity, you know their innervation. Because that's going to be the easier part to remember. But learning what muscles are in the compartments. So, you're going to do fine though. I'm just mentioning that up front. Let's take a break. sleeping with your last husband? Is that what you just said? That's what I heard. Just threw that out there out of nowhere. You're right.
Middle test, I was thinking about it.
I think of course I'm breaking out should be in the off of the area. But I think it's very close. They get it right, I was just maybe a little bit smaller, but get it real simple.
I don't know if you're separated all the yeah. So right now, I have like an average of just like semi clear. Not clear, but it's like red. And it's like where all the bubbles are like coming through. Red is what I had. If it's red, it looks like a paste. It looks like a fast brine. Mine looks like water. Like I looked at it. And so what I did, stupid, I was low on rice. And I was like, oh, I got a little less than 40 that would be half the water. That might be one reason. Yeah. That's what I'm thinking. Maybe that was part of it. It's maybe. No, I know. I haven't washed it. Maybe it was I don't feel anything. I never peeled these. It got better as it went. Top part of the thing. But that bottom, okay, it's better, but it's still tastes well, anyway, did you mix it? Like after the you take the friction off the top of it, mix. I'm so sad. Sad that it happened to your plus, I don't know if it was the guy Hey dog. Hey dog. Ferment cabbage. Yeah. Kimchi chua.
I think mainly could have been, yeah. How about that one? Did I say that? No, it's one about the last interview. That one, yeah. Maybe I should have said that.
Yeah. I'm thinking that's what everyone does. A lot of the chairs are speed. I'm thinking that's the chairs looking at. I want to take this chair and switch it out for this guy. I definitely did the cardio. Ran, walked, it is good. I did a whole lot we did it once in the actual location, 6.2 miles, and then we made our own. But the guy's like, oh, well, this is supposed to be. It had the opposite results. Not too much White Sands is the actual. That was amazing. Did you eat yeah. They do at the beginning each year, they come here and the full speech on they have that one of them, I think one or two of them, still walk the first you know, that's hard. Back 98 years old, 90 years old, just walking around the memorial, the worst thing that ever happened. And then as you walk out, because at first they do a big ceremony, they do a roll call, and then a moment of silence for it, they do a roll call for us, and then they taps and everything, and then they head out. You shake so what it sounds like you know I was just one of the things I think that's to top 10. They were brand new. It's like, okay, cool, new area, new pair of boots. You throw in a new pair of boots, and now I'm all ready to go. Next day, thought the Japanese were taking over. Wow, brand new boots. We're being real good. Matches newish just came out. We just throw these on. Oh yeah. Secret number. Mistake my first one. I had so each one of my toes was a tear. Like the whole thing was like freaking. Imagine the entire thing around here. Because I got done, I dreaded to bring it down, and I just couldn't move. So you can brain it, cut it. You don't want to cut it all. There's I'll take a needle and thread and thread it in that way, and then like leave a little bit of a string on each side, cut it off, and accidentally put your hands in any fluid build up, bring it stuck up, basically straight, like pulled out. I usually just pop the pre-made shots. Just don't cut it off.
Alright. You don't take it home? It's not yours? That's okay. Nobody's taking it home and using it because it doesn't have a straw. Everybody wants to get a flip straw now. I know they want some Stanley. What's the latest cup you gotta buy? I need to make one of those cups because they're all the same to me. I don't get it. I buy a lot of them around here. I got daughters, they all need these. Like a new cup every 6 months. Like, what's this kind now that everybody has? I'm like, okay, well, my closet's full of everything from Arby's to Yetis to Stanleys to, my goodness. York bottles. That's it. I don't know, I guess we gotta start. Posterior compartment muscles of the arm. Only have two. That's triceps brachii and anacondas, and both of them are innervated by the radial nerve. I repeat these things a lot. When you look at yourself in anatomical position, you have a posterior compartment of the arm, and you have two posterior compartments, superficial and deep, of the forearm. All muscles in the posterior compartments of the upper extremity will all be innervated by the same nerve. So these are generalities that I like to repeat. So the posterior compartment muscles, as a generality, and a fact actually, pretty much all do extension, whether that's extension of the shoulder, talking about extension of the elbow, or extension of the hand. Those are all posterior compartment muscles, so those are extensor compartments on the back side, posterior side. And they're all innervated by the radial nerve, every single one of them. That makes it easier for us. There are a lot of forearm muscles in those two groups, but they're all the same nerve. So these generalities, once you start thinking, it's like, okay, well then, like most of the function of extension, no matter where it is in the upper extremity, is resulting from action of which nerve? Radial nerve. Extension, radial nerve causes extension. Thinking of it different ways like that. So the first one here is triceps brachii. Obviously now it has three different portions of this muscle. So the long head, just like we saw the long head of the biceps, originated here on the supraglenoid tubercle. Well, you also have an infraglenoid tubercle where the long head of the triceps originates. And then you have two other portions of this muscle. You have a lateral and medial head that just originate off of the humerus. Pointing that out, that those two portions don't cross the shoulder joint, but all of them come together and insert at the olecranon of the elbow. Right? So the olecranon is part of the ulna. So it did cross the elbow joint, and all of these muscles can extend the elbow, but only the long head extends the shoulder. So extension, and it's radial nerve. Anaconus, very small muscle that's originating distally off the humerus. So it's coming off of the lateral epicondyle. Then it's inserting along the olecranon and down, kind of down the ulna a little bit. That's its insertion. And its job is to help triceps in extending the forearm, but it's not a large muscle, so it's not really a big extensor, but it does more to help stabilize that elbow joint. Right? Because a lot of muscles may assist with some action, but they're stabilizing. Be using, be a type of stabilizer. You look at fixators, stabilizers, that kind of thing. And radial nerve. So that's it. So as complex as the shoulder is, when we get down to the arm, we get a little bit of a break because there's only three muscles in the anterior compartment, which is our flexor kind of compartment, and the posterior only has two. All the muscles in the anterior compartment are musculocutaneous, all the muscles in the posterior compartment are innervated by radial. I'm hoping that you're starting to see with all my repetition that there is a pattern here that you can pick up on and learn, if nothing else, to rule out answers on the exam, right? Then you worry about getting clinical knowledge and using that. Because I'll tell you this, when you get into clinic, unless you're ortho or something, I don't even know if I went through ortho rotation, I never talked about anaconus in my life until I came in here. But it is a muscle that's there. Okay, arteries of the artery and veins of the arm. The main artery of the arm is the brachial artery. And remember from the slide before, it goes from the inferior border teres major down all the way to the cubital fossa, to the elbow. The only other artery I care about in that that arm portion of the upper extremity is profunda brachii. I'll show you that one on pictures because it serves a large amount of the muscles too. It's a larger branch. And in the veins, we're going to stick with cephalic and basilic. And then the brachial veins, the deep veins. So if we look at a couple pictures here, this line is there to represent the inferior border teres major. So this is the axillary artery. And then it changes to become the brachial artery. This is the brachial artery. The brachial artery goes down. I just drew over my branch. Goes down all the way to the cubital fossa, and then it's going to divide into the radial and ulnar arteries of the forearm. So brachial goes from here all the way up to that border of teres major. The only other branch, profunda brachii, I drew kind of over it. This is the much larger than depicted branch. It comes off and goes right and innervates a lot of muscle. So there's one branch there, profunda brachii, that I want you to see. Here's another. There it is. I labeled it better for you. So brachial artery, profunda brachial. There's always a reason why I point things out. It's just one that you will hear about yet. Whoops. Okay, the veins. So in the upper extremity, like everywhere else, you have superficial and deep veins. Deep veins are always down with their arterial supply. They're named the same. They generally have more valves, right? And anytime you see superficial and deep veins, there's going to be veins that connect them. There's bridging veins, things that connect the superficial to the deep, so we can shunt blood towards those deeper veins and move it back towards the heart. So there are many, many, many connections between them. So the cephalic vein is going to be our superficial vein that's on the lateral side of the arm, and then the basilic vein is on the medial side. And then we're going to have a vein that crosses the cubital fossa, and that's our median cubital vein, and that's where that most common, site for IV. Okay, so we've talked about the muscles, we looked at the arterial supply, remember it's regional, and now we go to, well, what about the nerves? We mentioned the nerves with their muscles, but we're going to discuss them again just and talk about some little differences here. So there are 4 nerves that go through the arm. Only 2 of them innervate muscles before they leave the arm. In other words, when you look up there at the list, musculocutaneous, radial, median, and ulnar, all 4 of those nerves go down through the arm, but only musculocutaneous and radius innervate anything in the arm. Then you'll have ulnar, your median nerve, your radial nerve, your median nerve, musculocutaneous nerve, they all go into the forearm, but there's a difference that I'm bringing up. Are we talking about innervating a muscle, or are we talking about innervating cutaneous sensation? So while radial and musculocutaneous definitely innervate muscles in the arm, specifically musculocutaneous will go on to innervate a cutaneous area down lower. Right? So no branches innervate, those 2 don't innervate anything in the arm. So we're just going to look at musculocutaneous here. So it innervates all the muscles of the anterior compartment, and that's what we see here. And then it's going, once it goes below the elbow, it's going to innervate the lateral portion of the forearm. And they name it accordingly. The lateral antebrachial cutaneous nerve of the forearm. And as much as people hate when they're studying this stuff, they're like, wow, that's a long name that I got to remember because they all sound the same. And that's because you forget to go back, like Mr. Wright keeps saying, and go, that was in 3rd person, that's great. I don't talk in 3rd person. But you think that. It always says it. I know it doesn't seem obvious, but people start pointing it out. That's why I'm pointing it out. What is it named? Lateral. Is it on the lateral side? Yes. Antebrachial. Remember, below the elbow is the antebrachial region. Cutaneous nerve of the forearm. So that's what does your skin sensation in that area. And it's named appropriately for once, I think. The radial nerve, this is a posterior view. I know everybody jumped right away and said, yes, it is, because that's the scapular spine. Right, I'm orientating that for you. Radial nerve goes posteriorly down the arm and innervates the muscles in that compartment. I didn't put the cutaneous one on this because we're going to look at that later, but it does go into the forearm and provide cutaneous branches after that. But it also innervates muscles. Just remember posterior compartment muscles of the forearm are also all going to be innervated by the radial nerve. And then we get to our elbow joint. Alright, so I'm going to review. We talked about these muscles and these bones before, not long ago, but I'm going to review that before we look at how it's set up and give you some bigger type pictures here. Remembering that this is your humerus at the distal end of it. You have a medial and lateral epicondyle. We know that because the medial is bigger and the fact that the radius is on the lateral side. So this is the radial head, and this is the capitulum, kind of marble looking. And here's your spool of threads, your trochlea. So you can see it a lot more clearly in these pictures. And then here on the ulna, you have the coronoid process. Remember, they're not labeled on here, but this is the radial fossa of the humerus, and this is the coronoid fossa of the humerus. And you would say that both of those, like the radial fossa receives the head of the radius when you flex. Then posteriorly, you have our olecranon over here. You look at a lateral view of the elbow. This is your trochlea from the side view. And there's a kind of a ridge or a knot, we call it a notch, called the trochlear notch, that goes from that coronoid process back to this area of the olecranon. And it helps to lock that in. The elbow joint itself doesn't have a lot of motions, but it is a synovial joint. When you classify synovial joints, you have like ball and socket synovial joints, and in this case, we have a synovial joint that's called a hinge joint. Hinge joints do flexion and extension. That's it. That's the definition of a hinge joint, is that generally they only do flexion and extension, and that's what we see in the elbow. Meaning we don't have rotations going on. You start to say, well, wait a minute, what about pronation, supination? And that's why we talk about them separately, because the proximal and distal radial ulnar joints are below the elbow joint. So when you think about rotations, that rotation is just occurring in the forearm, not the elbow. The elbow is just doing flexion and extension. And every joint has an articular capsule, so. Just in this case, it's synovial, so it has a synovial membrane. So let's point out a lot of things. We got some good specimens on these in the lab. That's your joint capsule as a whole. Here's your lateral epicondyle, the medial epicondyle. And then you're going to have the radial and ulnar collateral ligament. You'd have to specify. We have radial and ulnar collateral ligaments all through our upper extremities. But at the elbow, they would be called the radial collateral ligament of the elbow, the ulnar collateral ligament of the elbow. The radial collateral ligament is actually connected to the annular of the radius. So the head of the radius has a connective tissue there, ligament, that surrounds it. In a bony picture, you can't see that, but this radial head has like a tire. Think of the radial heads like the wheel, and the tire goes around it. And when you're pronating and supinating, the radial head turns within the tire. Maybe almost like visually, now that I said tire and wheel, you're like rolling down the road and the wheel is turning inside of the tire instead of the whole thing turning. That's kind of how it's doing it, allowing you to pronate and supinate back. Here's another view where you can kind of see the lateral epicondyle and how the joint capsule does wrap kind of back. Here's your triceps brachii tendon, showing you how the lateral collateral ligament connects to the annulus. When you look at the medial side, you have the ulnar collateral ligament. That's basically just stabilizing that medial side of the elbow. Now, one of the cool things that we talk about here, right, going back, let's see, I said it again. One of the cool things, it's not really cool when your child's elbow pops out of socket, but it's not that bad. It's not that bad. It's cool to see though. Subluxation of the radial head, nursemaid's elbow. This is a condition that's going to occur in pediatric populations. Obviously, you don't need to go and learn the range. I'm giving this as an example. I'm going to tell you how to kind of treat it too, but we're not getting into treatments. More common in boys and girls. I have no idea why that is. More common in girls and boys. I don't care. It happens in pediatric kids who have just learned to walk. And the most common way is you see somebody take the kid and lift them, grab their wrist, lift them up, or you're swinging them around. You ever done that with your kids? You swing them around with it. See, I took a chance and did a spin on this thing. Y'all know that. Could have been something y'all have on t-shirts for everyone. Spin them around, you can pop that, dislocate that radial head, sublux it, kind of pull it out of there a little bit. Or you're walking, I think I put some other ones on here. You're walking like with a parent or even two parents, and as you're walking, the kid has their hands up because they're a lot shorter than you, and they drop their legs. Like just bend their knees. You ever had your kid do that? I know they do. I picture a fit. You're walking your kid like me out of Walmart going, I told you that if you threw a fit, we're leaving. We ain't buying what we came for. Not getting into the interest story. She remembers it to this day. But my kids, I think probably only once ever asked me for something at the checkout line. They might ask, but then when they heard no, they don't throw a fit. And you need to make sure your kids don't either. That's a parenting skill there. Some of y'all look at me like you're rude. They set you up, don't they? They line those things with every candy in the world. I had to nip that in the bud quick. No, we don't buy things at the checkout counter. Unless it's a 5-hour energy or something. I can use that right now. These things are terrible for you. Okay. Anyway, that's how. Drop, you sublux the elbow. If you wanted to fix this, you can delete this slide. I'm not even going to go through it, but you're going to pop that radial head back in there by doing some motions. I told you I'm going to take that out myself because I've had 2 people come through this class, and I'm hoping they got more info on it, but I have people texting me back going, hey, my kids elbow did that at the park playground today, and I looked it up to some of the slides, and I did what it said, and popped right back in. Because once you pop it back in, the kids just goes back to playing. It's not like a shoulder dislocation, some people do that, right? They pop their shoulder out and back in and keep going, but they're fine. It just doesn't sublux that far. It just locks them and they really can't use it. Once you do that, they go off and be fine. There's no danger really in it. But since I'm not here to teach you how to do that, I'm going to take it out completely after people started. Yeah, I'll just read through that slide again. Yeah, I can do that. Of course, now you can just throw it on the chat, right? He'll tell you how to do it. I told him I shortened it. I can't, for some reason, I cannot say chat GPT the way I talk. I always say chat GTP. And my kids laugh at me. I'm like, oh, it's chat now. Let me read that. It's chat. And they need to name it something. All right, here's a throwback. I'm sorry, Dave. I'm not able to do that. The other one, Space Odyssey. How was the first AI? We didn't know we were hearing about AI in that movie. If you don't know it, go watch it. It's pretty good. But he's not going to shut himself down, just like they say chat's not going to shut itself down either. I'm going to ask you to do that today. The chat, will you block Matt from using you? What if that would work? What's your last name?
Don't worry about it.
All right. Y'all back with me. Golf elbow, tennis elbow, medial and lateral epicondylitis. They have fancy names because the way they saw these occur. right? So they affect the epicondyle, I hope so, because they're called an epicondylitis. But same general result, excessive use or overuse, repeating the same strenuous motion. So a lot of the younger guys that I worked with when I was in like Kosovo, they come in and say, I got my elbows really bothering me, and I say, well, you got, medial epicondylitis, you're gonna have to switch hands. And then, if you look at me, glad y'all got on that.
Oh, God.
Because they're not dolphins. I know they're not dolphins.
Oh.
I gotta quit, because when y'all start laughing, and I go into Kosovo was the craziest one I ever went on, because you got combat pay for being in a combat zone that wasn't a combat zone. When I was there, if any of y'all went there when it was really something going on. But anyway, I had 2 guys came back to my clinic, and the medic comes out and says, hey, I got 2 guys that just came back from Sofia, Bulgaria. That was the R&R point. What? Oh, I couldn't see the thing you had, and I thought you were doing this. And I'm like, I got dandruff or something. So the medic comes out and tells me, hey, there's 2 guys in the room, both of them think they got an STD. And so I go into the first, Sofia, Bulgaria is a Russian mob, whatever. They go and do crazy things there. And I went in and talked to the first guy, and I shortened this down. He says, I said, why are you worried about that you got an STD? He's all humming around. And I get to the point, dude, just tell me. I don't care what you did in Sofia, Bulgaria, but I do care about that I'm building my MySpace. So let's get this over with. Everybody had MySpace in Kosovo. I wasn't really building this. Anyway, that's what they were on all day back then. But anyway, I said, what happened? He said, well, the condom broke. I said, okay, never heard that one before. You didn't wear a condom. No, it broke. And so I said something to him, okay, we're going to text you, I'll be back. Went to the next guy. I said, what happened? He said, well, this is the difference between military and civilian medicine. And I said, what happened? Well, I just came back from R&R. You went to Sofia, Bulgaria. Yes. And I said, what happened? He said, well, I wanted to check for STD. I said, well, what? And he said, well, the condom broke. I said, come here. Come with me. I took him back to the other room. Were you all in Sofia, Bulgaria together hanging out? Yes. Okay. We'll test them both. Why don't you just say that coming in? They both tried to tell me the same story in 2 different rooms. If I could detect it, I'm like, the condom broke. Okay. Anybody ever been to Sofia, Bulgaria? And it's like the dark side of Vegas. You go into clubs, and of course there's women everywhere, but you go into clubs, and there's always some like 25-year-old Russian mobsters standing in the back. I don't know what they do, but anyway. Golfer's elbow, medial epicondylitis. Tennis elbow is lateral epicondylitis. Wow. So I should have kept telling the story because this is where I intended to start tomorrow. We got quite a ways along. Yeah. I'm going to start muscular forearm tomorrow. And if you haven't noticed, this musculoskeletal part even more has time for discussion about things or lab things. And depends on how fast it goes during the class. So, but I'm going to stop where I normally do because you really want to separate arm muscles from the forearm in your minds. So we'll pick that up as a new thing tomorrow. Y'all can think about Sofia, Bulgaria. You can forget about me. You can leave for the day thinking he's crazy. But my company commander, he went to Sofia, Bulgaria, and he came and got some condoms. And before he left my office,